So Sirman, can you talk a little bit about what kind of symptoms patients sometimes present with, and what are the unique challenges towards working up patients with NETs?
Well, John, as you know, I mean, diagnosis of NETs is challenging, not only due to the uncommon nature, but most of the symptoms are nonspecific. Most patients would present with things like bloating or abdominal pain. The amount of patients that present with what we classically are taught in medical school of carcinoid syndrome, the flushing, wheezing, bronchospasm is actually a minority. And unfortunately, I think we probably miss the diagnosis as a community quite a bit, and that leads to a delayed diagnosis. So I think it's something we need to work on, is improving the diagnosis, because often the symptoms are just not specific enough.
Right. One thing we see quite frequently is patients with small bowel NETs with mesenteric disease presenting with recurrent bowel obstructions year after year. And either the CT scans are not done or the mesenteric masses are not recognized. You can see them in retrospect, but they're often missed, leading to delay in diagnosis. And of course, you know, when it comes to working up patients, once you've established perhaps the pathological diagnosis of NET, there are certain things that are unique to neuroendocrine tumors. So somatostatin receptor imaging, of course, is one of them. In the past, we used to do octria scans. Many of them were quite crude. These days, gallium-68 dotatate scan, the NET spot, has really improved the sensitivity and the resolution, ability to detect small lesions, and often ability to detect primary site. So the gallium-68 dotatate scan has really become an important part of initial patient workup. And then, of course, recognizing hormonal syndromes and ordering the appropriate hormonal tests. For example, in patients with diarrhea and flushing, obtaining urine 5-HIAA or serum serotonin or even blood 5-HIAA. In patients with pancreatic neuroendocrine tumors who can present with very myriad symptoms such as heartburn, diarrhea, hypoglycemia, weight loss, you know, recognizing the important hormonal syndrome, I think, is an important part of the workup. There's a lot of controversy these days, though, about nonspecific tumor markers like chromogranin. What are your thoughts on that?
Listen, John, I think chromogranin A is probably the best biomarker we have right now, but I do think we do need to realize that there's a lot of reasons for false elevation of chromogranin A. Things like protein pump inhibitor use, even hypertension, a lot of other medications, even diet. So I think we have to be very cautious about using chromogranin A as a diagnostic tool. I think it can cause a lot of anxiety, not only for clinicians, but for patients as well. One thing I do want to mention, John, I think we should talk about is the importance of pathology and having good pathological impact in terms of when we do diagnose patients. There's a lot of features on the pathology. So when you see a pathology report, what are those key features to make a neuroendocrine diagnosis and to start planning your treatment that you look for on a path report?
Yeah, so these days, a pathology report that simply says neuroendocrine tumor or carcinoid tumor is inadequate. Mitotic rate and Ki-67 should be measured on all patients, leading to tumor grade, which is low, intermediate, and high. And ideally, especially with the high-grade tumors, you would want the pathologist to also comment on differentiation, because we realize, of course, that not all high-grade tumors are poorly differentiated. So I asked the pathologist to independently evaluate the tumor grade, typically measured at a hotspot, and also comment on the tumor differentiation, because those things are usually correlated to each other, but not always.
And this new phenomena, or in this new description now of a well-differentiated G3 neuroendocrine tumor, I think is very important. And as you said, it's important that we both understand the Ki-67 and mitotic count, but also the differentiation. How about for immunohistochemistry? Is there anything you look for specifically when you're making that diagnosis?
Well, chromogranin and synaptophysin are standard neuroendocrine tumor features. There are certain additional stains, such as CDX2 or islet-1, that can be done to help identify a primary site in cases of occult primary. I'd say usually with our modern radiologic techniques, we can usually identify the primary, and of course if there's a mesenteric mass in a typical patient with carcinoid syndrome, you can pretty much assume that the primary is in the small intestine, but occasionally those additional stains can be helpful.
How about TTF1? Do you find that useful?
TTF1 can, is positive in about 50% of lung nets. It's not specific and not that sensitive, but I suppose it can be helpful in some cases.